Hello all, welcome back to the Physics Development Ed. This had been a long time before we could catch up again on the ECG series. So today we're going to talk about ST segment. ST segment is the biggest, most topic when it comes to ECG apart from arrhythmias. So I will split it into two sessions. The first session we will focus on the most important one. And in the second session, we will try to address the other variants, other conditions where we can have the ST elevation. So what are we going to talk today? We're going to talk about the ECG and ST elevation MI. ECG and ST elevation MI. Just give me a thumbs up if I'm audible to all of you. If I'm live and audible to all of you, I am not able to see myself live. Okay, cool. I think I'm live and visible to you guys. Okay, so let us start with the ST segment. First, we will understand what is ST segment, and then we will talk about the ST segment elevation and ST segment elevation MI. What is ST segment? ST segment refers to that isoelectric line between the ventricular depolarization and repolarization. So we already know that T wave is ventricular repolarization wave and QRS is our ventricular depolarization wave, and anything between that isoelectric line is what we are going to call it as ST segment. And I'm reiterating again, there are two terms that we should be very much familiar when it comes to ECG. One is segment and the other one is interval. Intervals always contain a wave. Segments are devoid of wave. Segments do not have any wave. So what is the ST segment? ST segment is the isoelectric line between QRS and T. So basically it begins with the end of the QRS here and then continues till the beginning of the T wave. So this is my ST segment. This is my ST segment. Good evening, Sean. Good evening, Sean. This is my ST segment. Okay. Now the first question. The one thing that one is not expected to miss on the ECG is ST elevation MI, right? That's our biggest fear as a doctor. I do not want to miss an ST elevation MI, whether I become a surgeon, orthopedician, obstetrician, or any other specialty. I should be able to recognize STEMI on the ECG, right? So, how do I recognize the ST segment elevation? Now, the point to note about the ST segment is the ST segment begins with the end of QRS, and the point at which the QRS ends, that point we are going to call it as J point. So to identify the ST segment elevation, there should be elevation of J point. And what is this J point? The J point is the end of QRS complex. Now on many ECGs or like many leads, you may not be able to see the end of S. If it is a proper S wave, wherever S ends, that point is my J point. And wherever the QRS ends with the R itself, the end of R, I will take it as J point. So in other words, J point is the end of QRS complex, whether the QRS complex ends with S or ends with R. The end of QRS is the J point. So this J point should be elevated above the baseline. Now what is the baseline? Reference point. I should have a reference point, right? The reference point is the PR segment. So this J point should not be on the same line as the PR segment. Then I can say there is ST elevation. So if this is PR segment, this is J point. In this picture one, both of them are on the baseline. So I wouldn't say that there is ST elevation. On the other hand, when I look at the next ECG here, this is PR segment, this is Q wave, R, and then as I have already told you, the end of QRS, whether the QRS ends with R or ends with S, I will count that point as the J point. So here, this is the J point. This point is the J point. So this point, comparison to the PR segment, is clearly above the baseline, right? The PR segment line is this, J point is above, so that means there is ST elevation. This much ST elevation we can notice. Definitely we'll go through the real ECGs. First we will understand the concept. If I have to identify the ST elevation, first I have to identify the J point. Once I have identified the J point, I have to compare it with the PR segment, whether it is above the PR segment or on the same line as PR segment or below the PR segment. So in this image, first image, there is no ST elevation. Why there is no ST elevation? Because the J point is on baseline. And what is our reference baseline? The reference baseline is PR segment. On the second image, there is clearly ST elevation which is present. Okay. And now when I take you through the third image, this is the PR segment. So when I compare the PR segment, where do I find the J point? J point is the end of QRS. So QR comes down and this is the end of QRS. I can see an angle being formed here. This point I will count it as J point. So this J point is definitely below the baseline. This is the J point. Compared to the PR segment, it is below the baseline. So in that case, I will count it as ST depression. This much lower it is. So this ECG image shows ST depression. Good evening, everyone. Good evening, everyone. Okay, so I think the basics are clear, right? What is the ST segment? It is the isoelectric line between QRS and the T wave. Segments do not contain a wave, so it begins with the end of S and ends with the beginning of T. Now this point, whether it is elevated or depressed or it is on the baseline, for that I will use PR segment as the reference point, and I will compare ST segment whether it is below the PR segment or above the PR segment. If it is below, we will call it as depression. If it is above, we will call it as elevation. And for that matter, we will primarily look at the J point. We have to first identify the J point. Once we identify the J point, if it is above the PR segment, ST elevation is there. If it is below the PR segment, ST depression is there. So let us go through a real image and then you should tell me whether ST elevation is there in this particular lead or not. I want all of you to concentrate on lead 2. This is lead 2. You should tell me whether there is ST elevation present or not. Whether I have ST elevation present or not. So you can identify tiny P wave. This is a PR segment. So that is going to be my baseline or the reference point. And now I have to identify the J point. What is the J point? J point is the end of S if S is visible, or the end of R. So here I can see a wave go up. I will call it as R. It comes down, goes up again, right? So here is the end of the S wave, the end of S wave. So this point is my J point. That is my J point. Now this J point in comparison to baseline, where is it? Definitely way above. Definitely way above. So that means this patient has got ST elevation in lead 2. Okay. Similarly, I'll take your attention to lead AVL, right? This is lead AVL. Now look at this and tell me whether there is ST depression or elevation, or the ST segment is on the baseline. You can see the P and PR segment. So this is my baseline. PR segment is my reference line. And when I compare it, like, where is my ST segment? This is the S wave, the end of S wave. This is where I find the J point. Now many of you often text me and ask, sir, how do I identify J point? That's a big headache. Right? All you have to do is trace the QRS, and QRS at some point in the process seems like take a sharp angle. Whenever an angle forms, that point is the J point. Like here you can see that S wave and it's forming an angle here, clear angle. So this point I will take it as J point. So this J point is definitely below the PR segment. So as you pointed out, this lead shows ST depression. So now we know how to identify ST elevation and depression. But then there are n number of causes for ST elevation. It can happen in electrolyte abnormalities. It can be a normal variant. It can happen in patients with early repolarization, left bundle branch block. So there are n number of causes. How do I identify that this ST elevation is indeed because of STEMI? So for that, American Heart Association has given some criteria. Like if these criteria are met, that ECG is highly suggestive of STEMI, especially in the context of someone presenting with chest pain. So that changes. We will call them as typical ST elevation. Typical ST elevation. Typical ST elevation is suggestive of STEMI. Now to call it as typical ST elevation, what characteristic should be met? The first and the most important characteristic that should be met is, of course, J point elevation. The J point should not be on the baseline. What is our reference line? It is the PR segment. There should be J point elevation. Many times what happens? This J point is on the baseline. Like S comes, J point is on the same level as the PR segment, but later part of the ST segment takes off. That becomes elevated. That is not typical of STEMI. Clear? So J point should always be lifted up, like you see in this ECG. It is above the baseline. Then second point, to call it as ST elevation MI, there should be ST elevation in more than or equal to 2 contiguous leads. Contiguous leads. Now, what do I mean by contiguous leads? Of course, I'm not talking about continuous leads. I'm not Shashi Tharoor and I'm not trying to complicate English. When I say contiguous leads here, it refers to those leads on the ECG which are representing the same part of the heart. For example, we know that leads 2, 3 and AVF. They are all representing the inferior wall of the heart. They are representing inferior wall of the heart. So they are representing same part of the heart. So among these three, if I get ST elevation in at least 2 of them or more than that, that is typical. But then I also know that 1 and 2 are not representing the same part of the heart, right? 1 is representing lateral wall, 2 is representing inferior wall. And in that particular ECG, if I get ST elevation only in lead 1 and lead 2, this criteria is not satisfied because they are not contiguous leads. In the ECG, they are continuous. After 1, I have 2. They are not representing same part of the heart. So then it is not typical ST elevation. Okay, that is the second criteria. Now the third criteria is very, very important. We identified that there should be J point elevation, but how much? 1 small box, 2 small box, or more than that. We have to identify how many small boxes ST elevation should have happened to say that it is typical ST elevation, right? So then the criteria is in leads V2 and V3, there should be J point. Now, where do I measure the ST elevation? I measure the ST elevation at the J point itself. So, J point elevation of more than or equal to 2 millimeters. That is 2 small boxes for males, and J point elevation of more than or equal to 1.5 millimeter, 1.5 boxes for females. This applies only to lead V2 and V3, where we often have 1 millimeter elevation even as normal variant. So I need 2 or more than 2 for males and 1.5 for females. In other leads, in all other leads, elevation of more than or equal to 1 millimeter. 1 millimeter refers to 1 small square is enough. Okay, so we will go back to the ECG that we were seeing and see if these rules that we just learned are applicable. For example, we were seeing this ECG earlier. Okay, so in lead 1, am I getting more than, see, in which leads I need 2 millimeter elevation in males and 1.5 millimeter elevation in females, that is V2 and V3, where 1 millimeter elevation is normal variant. That's why we're counting higher numbers as the entry criteria. If I look at lead 2, 1 small box ST elevation, that is J point elevation, is sufficient to call it as typical. So when I look at it, how many small box ST elevation is happening? This is my PR segment. This is PR segment, so that becomes the baseline. Where is my J point? J point is sitting here. So that is roughly 1, 2, 3, 4 small boxes. I need 1 small box or more. It is clearly more than that. So that means it satisfies the criteria for the typicality. It satisfies the criteria for typicality. Okay. So that is the third point. To summarize again, to call it as typical ST elevation, what do I need? J point should not be on the baseline. Whatever leads I am seeing ST elevation, J point should be elevated. Number 2, I should find ST elevation in at least 2 leads which are representing the same part of the heart. Then number 3, V2 and V3 leads. There I have little higher cutoff to call it as ST elevation, and in other leads little lower. In all other leads, more than or equal to 1 millimeter or 1 small box elevation of the J point. And for V2, V3, for males, 2 small boxes, and for females, 1.5 small boxes. When these criteria are met, it is typical ST elevation. Now there is a last point. And on an ECG, this last point is the surest sign of STEMI. If any teacher asks you, What is the definitive sign of ST elevation MI on the ECG? The last point that I'm going to tell you, that is the surest sign. What is it? Presence of reciprocal changes. Now, what do I mean by reciprocal changes? If you have followed me from the earlier videos on the ECG, then you know that different leads are looking at different parts of the heart, right? And then there are few leads which are looking at the same part of the heart looked by other leads, but from the diagonally opposite direction. And in that case, the primary leads are expected to show ST elevation if there is myocardial injury. And these leads which are looking at the same part of the heart from the diagonally opposite direction, we will call them as reciprocal leads for that particular part. There we are expected to see ST depression. To give you an example, on a standard 12 lead ECG, 2-3 AVF, 2-3 AVF are reciprocal to 1 and AVL, 1 and AVL. Umar, I'll come to that. Okay, so these are reciprocal to each other. We should always remember, Umar, the AVR is looking at the heart from an opposite direction from any other leads. So AVR is a lead which is inverted on your ECG, right? So in AVR, getting ST elevation, we have given a name for that called as AVR sign, which indicates the left main coronary artery occlusion. Those variants we will discuss later. First, we will understand the basics of ST segment elevation MI. Okay, so these leads are reciprocal to each other. That means if I have inferior wall MI, this is inferior leads, these are lateral leads. So if I have inferior wall MI, I am expected to see ST elevation in 2-3 AVF, right? ST elevation in 2-3 AVF. If this is truly a STEMI, then 1 and AVL are supposed to show ST depression. If I get ST elevation in these leads, but I do not get ST depression in the reciprocal leads, then it is not a case of STEMI. And presence of reciprocal changes on the ECG is the surest sign of ST elevation MI. The other findings can be mimicked by various other conditions, but if you get reciprocal changes on the ECG, it is the surest sign of MI. Let us look at one ECG and see if we get that. I think we just agreed that lead 2 has ST elevation in this, right? Because J point is here, right above the baseline. What about lead 3? This is PR segment, Q, R, S and S ends here, and you can see that there is an angle formed between the rest part of the ECG and the S. So this point, I will count it as J point. This point is definitely way above the baseline, and it is definitely more than one small box. So lead 3 also has ST elevation. And what about lead AVF? Yes, lead AVF also has ST elevation. PR segment, Q, R, S comes down, S goes up, and then I can see an angle being formed. So this point, I'm taking it as J point. So this point is way above the baseline. So on this ECG, I think all of us now can agree that there is ST elevation in lead 2, lead 3 and AVF, lead 2, 3 and AVF. If it is truly a case of STEMI, what do I want to see? Lead 1 and AVL are reciprocal for this lead. There should be ST depression. If I don't find ST depression there, I have to re-question my diagnosis. So we'll visit 1 and AVL and see. So when I see 1 and AVL, what do I notice? PR segment. So this is going to be my baseline. Where is the J point? On the segment, above the segment, or below the segment? Ilham Azili, we will discuss the lead placement, which lead is representing which wall. We'll come to that again. Okay. First, we just understand to recognize ST elevation, ST depression. Okay, so here I can see R go up, S comes down. This is the end of S. I can see an angle here, clearly an angle formed, right? So this point I take it as J point, which is definitely below the PR segment. Next lead, it is quite clear, right? It is definitely, this point is definitely below the PR segment. So that means there is ST depression in 1. Okay. What about the lead AVL? PR segment, R, S comes down, and an angle here, that's the end of S wave. So this point is the J point, which is definitely below the PR segment. So what do I learn here? Yes, this ECG has reciprocal changes. So on this ECG, I'm very sure that this patient is going through inferior wall MI, and whatever ST depression I'm seeing in 1 and AVL, these are reciprocal changes. Clear? Okay. So in summary, I want J point elevation. At least two leads representing the same part of the heart should show ST elevation. And if those leads where ST elevation is seen, if they belong to V2 or V3, then minimum 2 millimeter ST elevation for males, minimum 1.5 millimeter ST elevation for females. And if it is other leads, then 1 millimeter ST elevation is enough. And if there are reciprocal changes present, I'm more than happy to make the diagnosis of STEMI. Okay. Now the question is, how will I recognize which part of the heart is affected in a patient with STEMI? Because I know how to recognize ST elevation, how to recognize ST depression, and many of you may be having this confusion that, sir, how do I get to know that ST depression is reciprocal changes, right? Okay, we'll sort that out. So to understand that, let us look at the heart. So when I sketch a heart, it has an inferior wall. Okay, it has a lateral wall, and it has an anterior wall and posterior wall. So this is the inferior wall of the heart, inferior wall, this part. And this part we will call it as lateral wall, higher lateral and lower lateral, higher lateral and lower part as the lateral wall, that is lateral wall. Then it has an anterior wall which is visible to me from the front, that we will call as anterior wall. So this is all anterior wall. And behind this, we have posterior wall. Unfortunately, I cannot sketch it. And somewhere behind this anterior wall, I have an interventricular septum. I have a interventricular septum. Let me label it as IVS. So when we take the 12-lead ECG, we are trying to represent lateral wall, inferior wall, interventricular septum, anterior wall, most part of the anterior wall, and then we generally in 12-lead ECG we do not have the representation for the posterior wall. So which leads are for the inferior wall? For inferior wall, I have lead 2, 3 and AVF. Lead 2, 3 and AVF are for the inferior wall. Which leads are for lateral wall? For higher portion of the lateral wall, I have 1 and AVL. Lower portions I have V5 and V6. And for the anterior wall, I have V3 and V4. They are for anterior wall. And for the interventricular septum, I have V1 and V2. So if I get ST elevation in V1 and V2, and if I'm suspecting STEMI, it is pointing towards interventricular septum being affected by the MI. If I get ST elevation in 2, 3 AVF, I'm thinking of inferior wall being affected by STEMI. If I get ST elevation in 1 AVL, I'm thinking of higher part of the lateral wall being affected. If I get ST elevation in V5, V6, lower part of the lateral wall. If ST elevation in V3, V4, the anterior wall being affected. In a standard 12-lead ECG, if you have seen ECG being taken up, we have never put the leads behind, so we do not have the representation of posterior wall. Okay, and when I sketch this, right, you can see that these inferior wall leads, they are looking at the higher lateral leads in the diagonally opposite direction, or the vice versa. The higher lateral leads, 1 AVL, are looking at the inferior wall from the diagonally opposite direction. That's why we say that these two sets of leads are reciprocal. Of course, I have not put any leads looking at the interventricular septum from the back, from the posterior side. So I do not have any reciprocal leads for V1 and V2. Okay. And then what about anterior wall? If I had put the posterior leads, those leads would have been reciprocal for anterior leads. But unfortunately, in a standard 12-lead ECG, I do not have the reciprocal leads for the posterior wall. Okay. But V3 and V4, the anterior leads can act as the reciprocal leads for the posterior wall, right? Like if this is the heart, I have put V3, V4 to see at this, right? But it is also indirectly, the same leads are indirectly seeing the posterior wall. So thus, anterior leads become reciprocal leads for the posterior wall. Okay. So we'll put all these numbers on a table so that we can relate it. Okay. So what are the main leads for particular wall? For inferior wall, it is 2, 3 and AVF. 2, 3 AVF. And as we just saw, 2, 3 AVF and 1 AVL, they are reciprocal to each other. So 1 AVL will be reciprocal leads for the inferior wall. That means if I have inferior wall MI, these main leads should show ST elevation and 1 AVL should show ST depression. they should show ST depression. And then V3, V4 are the main leads for the anterior wall. There are no reciprocal leads in the standard 12 lead ECG. If I put posterior leads, then it can be. Okay. Lateral wall, 1 AVL for the higher portion, and for that we have 2, 3 AVF acting as the reciprocal leads. On the other hand, V5, V6 are for lower leads, and we do not have any reciprocal leads for them. Interventricular septum or septum in general, V1 and V2 are the leads. They do not have reciprocal leads. Now, posterior wall. Posterior wall normally does not have representation on the 12 lead ECG. Similarly, right ventricle does not have the representation on the 12 lead ECG. If I am suspecting right ventricle being affected, I need to add additional leads. Similarly, if I am suspecting posterior wall being affected by MI, I need to add additional leads. So when I add these leads, we will call it as, because we have already done V5, V6, the rest leads we will call it as V7, V8 and V9. These are going to be my posterior leads. These are of course added additionally. Basically what we do is we take a 12 lead ECG, and if I am suspecting that patient has got a posterior wall MI, I have to place 3 leads extra posteriorly and re-record the ECG. Okay. So now that we have idea, the question is, when do I suspect? When should I put those extra leads? When should I suspect the posterior wall MI, right? Now, as I've already told you, the anterior leads are reciprocal leads for the posterior wall. So if I get ST depression in V3 and V4, if I get ST depression in V3 and V4, it may be pointing towards the ST elevation in these leads. So if I put these extra leads, I will be able to catch that finding, right? Clear? So take a quick look at the table. Inferior wall, we have 2, 3 AVF, and for it, we have 1 AVL as reciprocal leads. Anterior wall, we have V3, V4. No reciprocal leads on a standard 12 lead ECG. But if I have put extra leads for posterior wall, these will act as reciprocal for anterior wall. Posterior and anterior reciprocal to each other. Lateral wall, higher portion, 1 AVL, for which 2, 3 AVF are reciprocal leads. V5, V6 for lower lateral, for which we don't have reciprocal leads. Interventricular septum, V1, V2, we do not have reciprocal leads. Posterior wall, normally not represented in a 12 lead ECG. But if suspected, we can add 3 extra leads. We will call them as V7, V8, V9 for the posterior wall. Okay. And V3, V4, the part of 12 lead standard ECG, act as the reciprocal leads for the posterior wall. So now what we will do is, having understood this, we will go through some ECGs and see if we can identify the STEMI, whether it is STEMI, and if so, which wall is being affected. Okay. So let us look at the ECG 1. I'll take you through the leads. You should tell me whether there is ST elevation in that lead or not, and whether that ST elevation is typical or not. Typical or not. Let us look at lead 1. Lead 1. What is our reference line or the baseline? It is the PR segment. I can see P here. If you are able to see, let me use red color to make it more clear. Right, this point. This is where I have the P, and then this is the PR segment. Right. So this is the line of PR segment, as you can see. And how do I identify the J point? Wherever S ends, or if I don't find the S, wherever R ends. How do I know R ends there? From that point, the next part of the ECG clearly makes an angle. So here I can see that R goes up, comes down, and here I can see that it is making up an angle. Right? So I will count this as the J point. So now tell me whether the J point is on the baseline or elevated. Of course, it is higher, right? It is elevated. Rest part is the segment. This is the T wave. So J point is elevated, and to call it as typical, how many small squares elevation I expect in lead 1? Remember, for V2, V3, 2 millimeter elevation for males and 1.5 millimeter elevation for females. For every other leads, it is 1 millimeter. That is according to AHA guidelines. So here it is clearly more than 1 millimeter. So that means lead 1 has ST elevation. Okay. Next, we will look at the lead 2. What do you notice here? This is the PR segment. R goes up, comes down, S, and then I can see that S is making an angle here. So this point I will count it as J point, which in comparison to the PR segment, it is below the baseline. That means there is ST depression, right? Here also it is quite clear. PR segment is here. Angle I can see here. So that's the end of the S wave. So this is the ST segment. This is definitely below the baseline. So in 1 I got ST elevation, in 2 I got ST depression. Okay, then in 3 also, now I think quickly you can agree that there is ST depression, right? Here is the ST segment angle here, this is the PR segment, so there is ST depression in lead 3 as well. Okay, and then what about AVF? In AVF also I can vouch that there is ST depression. So S ends here and you can see the angle being formed here, clearly an angle, and this is the PR segment, ST segment is below it. So what did I notice? In 1 I got ST elevation, 2, 3 AVF I got ST depression. What about AVL? AVL. R goes up, comes down, right, and angle is being formed here. So this point I will take it as the J point. This is the PR segment. So compared to the PR segment, J point is elevated. It is one small square or slightly higher, right? Here it is even more clear. It is almost 2 small squares. So there is ST elevation in AVL as well. Okay. Then you should now tell me, what about V1? What about V1? How do I identify the J point? PR segment, R goes up, S comes down, S goes up. Here it forms an angle. So this point I will take it as the J point, right? You are able to pay the attention. This point is the J point because that is where an angle is formed and rest part is the ST segment. So this is my J point. In comparison to PR segment, it is definitely elevated, right? V1 we have ST elevation. Okay. Now to call it as typical, V1 needs to have 1 small square or more, right? Only V2, V3 need to have higher, that is 2 millimeters for males and 1.5 for females. So when I look at this, what about the segment here? This is a PR segment, my reference point. Okay, and this R goes up, comes down, right? R goes up, comes down, and this is the end of my R wave. So this is my J point, and this is my PR segment. So J point is way above. I need 2 small square. It is definitely more than 2 small squares. So in V2 I have ST elevation. V1 also I have ST elevation. What about V3? V3 also seems to have ST elevation because R goes up. This is my PR segment is here. R goes up, comes down, ends here. So J point, this is the J point. This J point is way above my ST segment. So I have ST elevation in V1, V2, V3. And then when I look at V4, there also I can see ST elevation. Like look at this, R goes up, comes down, forms an S, goes up and ends here. So that is my J point. This is my PR segment. So there is ST elevation. ST elevation. Okay. Those are not biphasic. See, this is primarily what you are seeing here is the R wave going up, coming down. Then it is the S wave. So the whole S wave is lifted up. This is the S wave. And the end of S, this is what I'm taking as the J point. So this is the S that you're seeing, the end of it is being taken as the J point. Okay, so now in what all leads we saw the ST elevation. I don't see ST elevation in V5, right? This is a PR segment and the J point is on the baseline, right? Look at this, this is PR segment and S comes, ends here, so it is on the baseline. So there is no ST elevation in V6. Is there any ST elevation in V5? Is there any ST elevation in V6? It appears to have ST depression in V6, certainly not ST elevation, right? So let us put down our observations. I saw ST elevation in 2, 3 and AVF. I saw ST elevation in V1, V2, V3, V4. And I saw ST depression in we saw ST elevation in 1 AVL and ST depression in 2, 3 AVL, right? Okay, so I saw ST elevation in 1 AVL, V2, V3, V4, V5 and ST depression in 2, 3 AVF. 2, 3 AVF. In whatever leads we saw ST elevation which was typical. It was showing the required number of the small boxes being elevated, right? So now, does it meet all the criteria to call it as typical ST elevation? Of course, yes. First, I had to have J point elevation. J point elevation was there. J point ticked. Second, I had to have more than or equal to 2 contiguous leads showing ST elevation. That can also be ticked because 1 and AVL, 2 leads representing the same part of the heart. V1, V2, two leads representing the same part of the heart. V3, V4 representing the same part of the heart. V3, V4 representing anterior wall. V1, V2 representing interventricular septum. One AVL representing lateral wall. So that is satisfied. Third, number of small square elevation required for individual leads, that is also satisfied. And the last one, reciprocal changes, right? Am I getting the reciprocal changes? If I'm getting ST elevation in 1 and AVL, I'm supposed to get ST depression in 2, 3 AVF. They are reciprocal to each other. So I'm definitely getting ST depression here. So reciprocal changes are also present. That means this ECG has STEMI, and I'm more than confident to call it as ST elevation MI because I'm seeing reciprocal changes. So now, STEMI we recognized. The question is which part of the heart is affected? Which part of the heart is affected? 1 and AVL are for lateral wall. Therefore, lateral wall. So there is lateral MI. V1, V2 are for the interventricular septum. V3, V4 are for anterior wall. So let me call it as anterolateral plus septal MI. As you see, it's not inferior wall MI. Inferior wall, whatever changes we got, right? ST depression. They are reciprocal changes for the ST elevation in 1 and AVL. So remember, ST elevation is the primary abnormality. So we can't say that ST depression in 2, 3 AVF has led to ST elevation in 1 and AVL. No. Elevation, whatever leads show, that is the primary abnormality. If it has a reciprocal leads, I may see their depression. So depression is just the reciprocal change. So inferior wall depression is reciprocal change for the injury of the lateral wall. There is no inferior wall MI. So I will call this as anterolateral plus septal MI, anterolateral plus septal MI, or because it is involving most part of the heart, we can call it as extensive MI. We can call it as extensive MI. Extensive MI. Okay. We'll go through one more ECG. Look at this ECG now. In what all leads we see the ST elevation. Okay. Lead 1, what do I notice? PR segment and J point is below it, right? This is the PR segment. This is the ST segment. This is where I have the J point, which is below. So in 1, there is ST depression. In lead 1, there is ST depression. Okay. In lead 2, what is there? PR segment, R, S, end of it. This is the J point, right? This point is the J, which is above the baseline. So this lead 2 shows ST elevation. When I look at lead AVL, PR segment, S and here, this is the ST segment. So this is my J point. That is definitely below the PR segment. So I will call it as ST depression, AVL ST depression. Lead 3, R goes up, comes down. This is the end. Then next is segment. So this is the J point, which is above the PR segment. So lead 3 also shows ST elevation. And same applies to lead AVF. NCR goes up. So this is the PR segment. This is the J point. So there is ST elevation in AVF as well. Okay. Then what about the lead V1? Lead V1, the PR segment, ST segment all appears to be on the baseline. Lead V2, P wave, PR segment, S and CR, J point. So all of them are on the baseline. Lead V3, same applies. This is the end, this is the J point, this is the PR segment, they are on the baseline. Okay. Then V4, again same, end, S and CR, this is the baseline, so they are on the baseline. Same applies to V5, V6. So in this ECG, where all I am getting ST elevation, I am getting ST elevation in lead 2, 3, AVF. These are the inferior leads. That means there is inferior wall MI. And to call it as STEMI, there has to be reciprocal changes in 1 and AVL, which we have seen, right? So that means this ECG has ST elevation in inferior leads, and as reciprocal changes to it, I have ST depression in 1 and AVL. So that means this patient has inferior wall MI. Inferior wall MI. Umar, very good, very good. Okay. Now let me take you through one more ECG. See this ECG and JF, very good. Very good. Okay. So when I see this ECG, do I see ST elevation in lead 1? PR segment, R goes up, comes down, lands here, an angle there. So this is my J point. Compared to PR segment, J point appears to be higher, right? So in lead 1, I can say that there is ST elevation. Same is much more clear in lead 2, right? Compared to PR segment, J point is way higher. This is where the R is ending. So there is ST elevation in lead 2 as well. Lead 2 as well. What about lead 3? Again, when I see it, PR segment, the R is ending way above the PR segment. So there is ST elevation in lead 3 as well. Okay. What about the AVL? Okay, I don't see ST elevation in AVL. Kind of appears to be on the baseline. AVF, yes, there is visible ST elevation. PR segment, R ends here. This is the ST segment. So this is my J point, which is above the baseline. So there is ST elevation. Okay. In AVF also, I'm getting ST elevation. Okay. So when I see lead V1, what do I see? PR segment is this, right? P appears to be inverted. This is PR segment. Then I have a deep S and it ends here. It is depressed. Compared to PR segment, it is low, right? So I would count this as ST depression. What about V2? V2 appears to be on the baseline, right? S ends here. This is a J point, appears to be on the baseline. What about V3? V3P, PR segment, this becomes the baseline. S ends exactly there, so it is on the baseline. Okay, what about V4? V4 PR segment, S ends here, so they are on the baseline. V5, I do see ST elevation, right? PR segment, R comes up, lands here. This is the ST segment. This is my J point, which is above the baseline. So V5, I can say that there is ST elevation. And I can say that there is ST elevation. This is a J point, which is above PR segment in V6 as well. So there is ST elevation in V6. Now tell me, is it typical STEMI features? Where all I'm getting ST elevation? 1, 2, 3, AVF, V5, V6 and ST depression in V1. What do you think is this? Is it typical STEMI? If it was a typical STEMI, remember, if I'm getting ST elevation in 2, 3, AVF, 2, 3, AVF, what should happen to 1 and AVL? 1 and AVL should have ST depression. But here I am getting ST elevation in 1, right? And there is no ST depression in AVL. So that means reciprocal changes are missing. So can I say that in this ECG, I am getting widespread ST elevation, widespread ST elevation and no reciprocal changes for ST elevation in inferior leads. If there was ST elevation in inferior leads and it was truly STEMI, I should have had the reciprocal changes, right? Okay. In this ECG, there are some more interesting features. We'll come back and see later. But now we know that this is not suggestive of STEMI because it is lacking the reciprocal changes. Okay. Now we will look at another ECG. When you look at this ECG, I want your attention to lead 1 and AVL. What do you notice? This is a PR segment. This is the end of R wave, right? Here is the angle. So this is a J point. This is the PR segment. Elevation, all of you agree, there is ST elevation in lead 1. This is a J point. This is a PR segment. Okay. What about the lead AVL? 1 and AVL are representing the same part of the heart. P, Q, R ends here, kind of angle being formed there I can see. So that is my J point. And this is PR segment elevated. 1 AVL elevated. Okay. Lead 2 is quite close to base isoelectric line, difficult to identify, but I can look at lead 3. So when I look at lead 3, what do I notice? PR segment, right? I have a deep S comes up here, an angle formed, right? An angle formed here. So that is going to be my J point. So this J point is definitely below the baseline. So lead 3, I can confidently say that there is ST depression. Then what about the lead AVF? Lead AVF, again bit difficult. This is appears to be the PR segment. R goes up, comes down, yes, it ends here. So this I will take it as the J point, slightly below the baseline, slightly below the baseline. When you look closely, PR segment, R, S ends here and an angle there. So you can see that this is the J point. This is J point line, this is the PR segment line, one small square below the baseline. So I will count ST depression in AVF. Okay. Then what else I notice? In lead V1, PR segment, this is where I have the J point. That is where the angle is formed. So that means there is ST elevation in V1. What about V2? V2 is so clear, right? Glaring in our eyes. The S goes up, ends here, right? That's my J point. That's my J point. This is my PR segment, way above. So there is ST elevation. In V2, V3, I need two small boxes. It is way more than that. V3 also, it's clearly visible that there is ST elevation. J point is here, PR segment is here. So it is way more than that. Okay. Then V4, again, PR segment, J point here. So there is ST elevation. V5, RS goes up. This is the J point. This point is the J point. This point is the J point. This is the PR segment. So again, there is ST elevation in V5. And what about V6? V6 also appears to have ST elevation. PR segment, this forms the PR segment, and this is one small square above the PR segment. So there is ST elevation in V6 also. So in what all leads I have ST elevation in this ECG? I had ST elevation in lead 1 AVL. That means which wall is affected? And also V5, V6. And also ST elevation in V1, V2. And ST depression in 2. 2 is not very clear. Wherever I've seen clearly, I will only document that. So I have seen depression in 2, in 3 and AVF. So is this typical now? Is this typical now? Yes, right. 1 and AVL is representing lateral wall, for which we have the reciprocal leads, which is nothing but 2, 3 AVL. Here I am seeing the ST depression. So that means these changes are reciprocal changes. Reciprocal changes. V5, V6 is also representing the lateral wall, and V1, V2 is representing the interventricular septum, and V3, V4 also we had ST elevation. I forgot to write. V3, V4 also we had ST elevation, which is suggestive of anterior wall involvement. So these are all the primarily affected structures, and these are the reciprocal changes. So where is the MI here? I have, again, I can call it as patient having anteroseptal plus lateral wall MI, or what we call as extensive MI, right? Anteroseptal or lateral wall MI, or again I can call it as extensive, because anterior wall is affected, lateral wall is affected, and interventricular septum is also affected. Now this ECG that we saw, which was not typical, the pattern was not fitting into it. This is actually a patient with acute pericarditis. In acute pericarditis, multiple leads, widespread ST elevation, which does not follow the rule of reciprocality. Like we saw here, there is no rule of reciprocality being followed. In fact, we see 3 changes in the acute pericarditis. The first thing is the PR segment gets depressed. The PR segment gets depressed. So if this is a P wave, the PR segment has got shifted from the baseline. It is usually depressed. ST segment gets elevated, and then we have a TP segment, which is between T and P wave, which is usually downsloping. It is going down like this. When you see clearly, you notice that PR is low, ST is high, and TP starts at point and then goes down, sloping. So when I'm suspecting this acute pericarditis, sir, you're telling that PR segment is depressed. So where is my reference point? Because in STEMI, I was using PR segment as the reference point. I was comparing J point with that. But here you are saying PR segment is depressed. So where is my reference point? We use the end of T wave, that point, as the reference point. So if I draw a line, that will be considered as the baseline. End of T, that will be the baseline. So here J point is above it, right? ST segment elevation. PR segment is below it. And the end of T, that is where TP segment starts. And this is going down to form the next P wave. So 3 segments all affected. PR segment depression, ST segment elevation, downsloping TP segment. And this downsloping TP segment, we call it as spodic sign. It is highly specific for acute pericarditis. When do I suspect? Patient will present with chest pain just like MI. If I have acute pericarditis, I will suspect when widespread ST elevation is seen, which is not following the rules of reciprocality. And on top of that, I see PR depression, ST elevation, and spotting sign. I will consider it as acute pericarditis. Okay. Now, in all these ECGs we saw, in this ECG, we concluded that patient had inferior wall MI. Here, anterolateral and septal MI or extensive MI. Here, no MI, right? Here again, extensive MI. Now, the only thing is, JNO need not be in all leads, widespread. Need not be in all leads. In fact, you may get depression of the ST in two leads. One is AVR, which is, as such, we know it's an inverted lead, and V1 also you may get depression. In fact, on that ECG I showed, V1 had the ST depression. So in V1, we get a PR elevation and ST depression if it is pericarditis. So the rule is not to see the ST elevation in all the leads. If it is widespread and it breaches the rule of reciprocality that we see in STEMI, you can consider acute pericarditis, provided you have other ECG features of acute pericarditis. Okay. So now the last bit we need to learn today is, we saw that this patient has an MI. We know anterior wall is affected, lateral wall is affected, septum is affected. Here only inferior wall is affected. Here it's not MI. Here again it is extensive. Can I identify which blood vessel is responsible? Blood vessel is responsible. Sunny Sheth, I have no clue about the organisms or microbiology. I think our microbiology faculty will be the right person to guide you on that. So she'll be available on the Telegram. If you ping her, she'll definitely answer that. Okay. So what we do is, we will complete this table by understanding the blood supply of these individual regions. Okay. So we have two major coronary arteries. Both arise from the aorta. One is the right coronary artery. The other one is left coronary artery. This I can also call it as LMCA, left main coronary artery. The right coronary artery, as it arises from the aorta, it goes on to supply the inferior wall, right? This is the inferior wall of the heart. So the major blood supply to the inferior wall comes from the right coronary artery. Few people will have the dominance of inferior wall being supplied by the blood vessel coming from the left side of the heart. Otherwise, for most individuals, the blood supply to the inferior wall comes from right coronary artery. Okay. Now, this left coronary artery splits into two. One is left anterior descending artery, which supplies the most part of the anterior wall, and most part of the anterior wall is formed by the left ventricle. And we all know that the most important chamber in the heart is left ventricle, because it has to contract vigorously to generate sufficient force so that the blood gets distributed throughout the body, and then from the tissues it comes back to the right side of the heart, right? So the main part of the heart is supplied by left anterior descending artery, which we abbreviate as LAD. Another branch of this left main coronary artery is called as circumflex artery. This circumflex artery supplies most part of the lateral wall, and then it curves backwards and goes on to join branches of right coronary artery and becomes the source for blood supply to the posterior wall. And in some individuals, it may be the dominant blood supply to inferior wall. But as a general rule, for most people, it is the right coronary artery which is the dominant blood supply to the inferior wall. So we have to always keep in mind which artery is supplying the blood to which part of the heart. So inferior wall is supplied by right coronary artery. In few individuals, it is left circumflex. Otherwise, most people, right coronary artery. Anterior wall is supplied by left anterior descending artery. Lateral wall is supplied by left circumflex artery. Interventricular septum is supplied by branches coming from the LAD. Most part of IVS is supplied by branches coming from LAD. So we will simply keep it as LAD. You can say septal branches of LAD or LAD. And then posterior wall, in most individuals, it is getting most part of the blood supply from RCA, some part from the left circumflex, right? RCA is the main dominant artery, some part from the left circumflex. Okay. So if I have inferior wall MI, that means most likely I have block in the right coronary artery. If I have anterior wall MI, mostly I have block in left anterior descending, or if I have interventricular septum being affected, again LAD. If I am seeing lateral wall MI, it is left circumflex artery, which is most likely occluded. And if I am seeing posterior wall, mostly RC, or in some individuals, circumflex. Okay. So with this, we will visit those ECGs, and you should now tell me which artery I should be expecting to be occluded. Inferior wall, right? Mostly due to what is the main blood supply to the inferior wall? It is the right coronary artery. Right coronary artery. Okay. Here it is no MI, right? This is actually acute pericarditis. I'll come to that. I'm coming to that. Acute pericarditis. Okay. So there is of course no block, just inflammation. Okay. Now in this ECG, anterior wall is affected. What is the main blood supply to the anterior wall? It is LAD. Septum is also getting LAD, and lateral wall is getting blood supply from left circumflex artery. So now you should tell me where is the block. Because to cause lateral wall MI, circumflex should be blocked. To cause septal, LAD should be blocked. To cause anterior wall MI, LAD should be blocked. So both of them, as we know, right, they are branches of left main coronary artery. Left main coronary artery divides as LAD and left circumflex. So if I block left main coronary, blood flow to the circumflex as well as LAD is cut. So I can get this extensive MI picture. Many of these patients collapse and die quickly because interventricular septum, then lateral wall, and the left ventricle, which is forming the anterior wall, they're all going dysfunctional in a very short span of time. So it can lead to shock and death. So death risk is very high when you have extensive MI. So this extensive MI is most likely due to occlusion due to left main or left coronary artery occlusion. Another ECG also had the extensive MI. So this also I can say it is due to left main coronary artery occlusion. Now comes the question. Sir, if I get ST elevation in 2-3 AVF, I know it is inferior wall MI. If I get ST elevation in V3, V4, I know it is the anterior wall MI. 1 AVL, V5, it is lateral. V1, V2, it is interventricular septum. But posterior, I have not placed leads, and until and unless I place leads, I will not get to know. So when should I suspect? Say until and unless I suspect, I will not add 3 leads. I will not do this extra ECG. I may not be able to unmask the posterior wall MI, right? So we will put one small note here. When to suspect posterior wall MI? When to suspect posterior wall MI? Number 1, though I have not put the direct leads for posterior wall, there are 2 leads which are acting reciprocal to it. So if there is truly posterior wall MI, then there should be ST elevation in V7, V8, V9. I have not put it, but if I put, it should be there. In that case, there should be ST depression in V3 and V4. So V3, V4 being reciprocal leads for the posterior wall, if they show depression, I should suspect the possibility of posterior wall MI, right? So whenever I have ST depression in V3, V4, depression in V3 and V4, because these are reciprocal changes for the ST elevation in posterior leads. So I should add 3 leads. Of course, I may end up finding the ST elevation there, and I will confirm the diagnosis of posterior wall MI. Okay. The second, what is the main blood supply to the posterior wall? 80% it is RCA, 20%, 30% from left circumflex. So any patient who has right coronary artery occlusion, he may present with inferior wall MI. So if there is a patient with inferior wall MI, I should be suspicious of the possibility of posterior wall MI, because they are receiving the blood supply from the same source. Like when you see this image, you can relate, right? So this right coronary is taking the blood supply to the posterior wall, and it is also taking the blood supply to the inferior wall. So if I block it proximally, blood supply to posterior wall and inferior wall both cut. So on a regular 12 lead ECG, I will only get the evidence of this inferior MI. And if I put those extra leads, then I may get the evidence of posterior wall MI, right? So that's why if I have patients with inferior wall MI, we should suspect possibility of posterior wall MI. In patients with inferior wall MI, we should suspect the possibility of posterior wall MI. So this is how, when we recognize ST elevation going methodically, first recognizing J point, whether the J point in comparison to PR segment is elevated or not. We will be able to recognize the true ST elevation. And once we have recognized, we have to see whether this ST elevation fit the basic rules to call it as typical ST elevation. J point elevation, ST elevation in at least 2 leads representing the same part of the heart. Then if the ST elevation is in V2, V3, J point elevation of more than 2 millimeters in males or more than 1.5 millimeters in females, and for every other lead, more than or equal to 1 millimeter, that is one small box. And any lead which has reciprocal leads, if there is ST elevation in the main lead, the reciprocal lead should show ST depression. When they don't show, it is not mostly STEMI, like we saw that ECG of acute pericarditis, where the main leads as well as the reciprocal leads were showing ST elevation instead of showing the reciprocal changes. Okay, then we have gone through the ECGs and we learned which part of the heart is represented by which leads. This is one thing that you need to spend some time to get a mental idea or a mental memory, that which leads are for which wall, so that you can recognize which wall of the heart is affected by MI, and you can predict what was the likely blood vessel which has been occluded in that particular case of MI. Okay, so with this I will conclude today's session. We have only learned the basics of ST segment. There are a lot of variants which may mimic MI or which may confuse a novice whether it is MI or not. The variants we will discuss in the next session. So we'll have one more session for ST segment, and then we will go to some specific scenarios like electrolyte abnormalities and the ECG changes, and then we will start with arrhythmias. Right? So with that, I'm signing off. I'll see you in the next class. Till then, good day.